Good to see you. Some of you I know very well. Some of you I don't know at all. And I thank Kathy for already kind of sparking the political discussion, because I'm not backing off of it. We're going to talk some more about it. She and I are cohorts in crime in our passion to do some of those things. And so as we get to the end, I'm going to be soliciting your help in that regard. So I was asked to talk about the surgical components of the care of a patient with melanoma. And so if you've ever seen me in my office, this may sound redundant, because this is what I tell folks all the time. But we'll have the time to go into a little more detail for some of it, and I am not afraid of questions at all. So if I'm in the middle of saying something and you have a question about what we just talked about, just speak up, wave your hand. We can stop, we can start. It doesn't bother me at all. I do have the pleasure of being head of surgery at the University, head of surgical oncology at the University of Tennessee, and part of the surgical component of our cancer center effort here in Memphis. I am from Memphis. I wasn't born here because my parents were out traveling and training when I was young, but they're from here, and grandparents were from here, and so Memphis is home, and it's been way too long before we've had something like this, a facility like this, to take care of the people of Memphis, and it's a very exciting time, and it's just such a pleasure to get to be part of it. There we go. I was chuckling as I was watching Kathy's slides going, I've got that one too. So you're going to see it, but repetition is good education. We do it with residents all the time. We do it over and over and over, right? This is just basically the incidence of melanoma. And we'll talk a little bit more about this at the end, but it's not going away. It's getting more and more common. It was something that everybody thought was kind of a rare cancer years ago, and now we can't go anywhere without meeting somebody that either has a family member or has personally experienced some component of this disease process. So it's definitely something that we need to talk about and be an active participant in. This is an interesting slide that the writing's small at the bottom, but it's basically all the countries and areas of the world and where melanoma is a problem. And we're right here. The blue is the incidence, meaning how many people per 100,000, and the red is how many people die. So the blue is diagnosis and red is deaths, and you can see we're way to the left. I didn't know this would work that way. Excellent, okay. Australia, New Zealand, and Northern Europe are ahead of us in that regard. We'll talk a bit more of that in a minute, but in the Asian countries, less so. Clearly it has to do with the type of skin of the people that live there, and geographically where on the earth they are. As you see this, the red is the worst areas, just to give you kind of an understanding of the epidemiology and the population relationship that this disease process has. Australia is red, United States, the whole of North America is red. Siberia and the Scandinavian countries are red, and South Africa is red. And thinking about that, why is that so? Think your history. I love history, so we're going to talk history a little bit. All the people from here started there, most of them. All the people here, except for the indigenous population, the Aboriginal people, started there as well. So you've got people of usually Scotch-Irish heritage that moved out of Great Britain into the other parts of the world, went on to populate those parts of the world over the last several hundred years, and they're in the wrong place in the world for the type of skin they have. In the United States in the late 1800s, back in the Irish potato famine, pushed a lot of people out of that part of the world. They came to the United States, they came down the eastern coast, they hit North Carolina and went over the mountains. They kind of liked Appalachia because it kind of looked like home, and then they kept going east. So the southeast United States is populated, the majority by Scotch-Irish people from about 200 years ago that became farmers, not great for your skin, worked in the Delta, and made a life there, and here we are. Those are my people, and we're right in the middle of that hot spot. So there's a reason why we see increased levels of this disease process in our country versus other parts of the world. I had a colleague that was presenting a paper recently in Japan on some melanoma aspects, and he asked me what I thought the incidence of melanoma in Japan was. I said, I have no idea, but I bet it's pretty low. And they were way to the right on that graph that we were seeing earlier. I said, I don't know who's going to be interested in the topic because they don't have that much of it there, but we do. Kathy's already shown you this, the ABCs and Ds and Es of melanoma. And the tricky thing is, and I do not want to be Dr. Schwarzenberger, because it is hard to know what's significant and what's not. All these things are indicators, and I tell people this all the time. Those things are not chiseled in stone. And I can probably look over myself and find several things that meet some or all of these criteria that are okay. And then I see people all the time that have a significant melanoma that didn't have any of these things going on. So while these are great indicators and great to use, and we beat people to memorize these because they're important, they're not the end all, but they're very helpful. And I found this ended up being probably the most significant one. Because if you're Scotch Irish, you got funky skin. And if you grew up in the sun, you got even funkier skin. And you're going to have little blemishes and things that are all going to meet some of these criteria. But when things start to change, I think it's important. What Kathy said about the ugly duckling, I heard a dermatologist say that at a meeting one time as a scientific term. I said, what are they talking about? And they're absolutely right, though. For some reason, sometimes something will catch your eye. As a physician, as a patient, as a spouse, and you'll think, that doesn't look that weird, but I don't remember that being there. When I hear people say that, it gets my attention because it really means something. For some reason, that one thing looks different than it used to be or wasn't there before. They can't even articulate sometimes why it is that they think it's important. But that's real. And so if evolution is going on with a lesion, it's important. I'm going to actually talk about dermatology in front of the chairman of dermatology, so bear with me. But it leads up to where the surgeon steps in. When a lesion is considered significant enough to biopsy, there's 3 ways to biopsy it. And if you've been in a dermatology world or a surgeon's office, you've experienced one of these 3. Each has its advantages and disadvantages. Shave biopsy is where the lesion that might be concerned, might not be concerned, we're just doing a sample to find out what it is basically just shaved off. Leaves a little circle where the lesion was, heals from the bottom up, tissue gets sent off to the lab. The advantages is it's quick and easy. There's no stitching involved, there's no suturing or anything like that. Disadvantages is it's just a sample. Doesn't necessarily take care of the lesion in that way. And both have, like I said, it's okay. Punch biopsy is an alternative way to do it, and I know that our dermatologists here would agree that if you see something that you really think is significant, somebody walks in with something that you think, oh my gosh, we got big problems here. Shave biopsy is probably not the best step. We just need a sample to prove what it is before we press on. And a punch biopsy is a different way to do that. Punch biopsy is just a little circular, little cylinder of tissue. That little round thing is actually a circular blade. And this looks kind of graphic, but I do them all the time with basically no anesthesia, and it doesn't hurt for most people. You just go down and take a little piece of tissue, and it comes out as a little plug, and we send it off to the lab. The nice thing about this is it gives you usually a full thickness understanding of the lesion, but it doesn't take the lesion off. And with any kind of biopsies, there's potential for what we call sampling error, where the one little piece that I took out may not be representative of the whole lesion. So we keep that in mind as we're doing biopsies. And the last is an excisional biopsy. This is not surgery for melanoma. This is just a way to get the lesion off to find out what it is. There's places where this is absolutely appropriate, and there's places where I kind of wish it hadn't been done. For larger lesions, I'd much rather have a nice sample to find out what it is if you're really worried about it, so we can do the appropriate next steps. For smaller lesions, where you can just take the whole thing off and be done with it, and you haven't stirred up a lot of problems down the road, we'll talk about that in a minute, then this is a great way to do it, because there's no question about sampling error. The whole lesion's gone, and it can be evaluated in its completeness. Prognostic significance of melanoma is this is just to show you the spectrum that we see. As Kathy said, like so many types of cancer, when we don't know how to prevent it, we know that intervening earlier is better. And so the thinner the lesion, the earlier the lesion, the sooner when somebody notices something, they have it evaluated, the better. And that just points out that the deeper the lesion, this is just a series of little lesions in this cartoon, the higher the stage, and you don't have to know even what stage means, but you know the higher the number, the worse the situation. So the deeper the lesion, the higher the stage, and this just shows the potential for going other places when you get really deep melanomas. So as soon as we can find out what's going on, the better. You see a lesion like this, well, it's kind of modeled, there's some darker areas and some lighter areas. That's where sampling error can be a problem, because you can get a sample of maybe the lighter area and it could be very thin and not realize that some of these other areas could be very deep. So you just gotta, as a physician, we take that in mind to think, all right, are we comfortable that this is representative of the problem before we make some big decisions? This is where the surgeon really takes the next step in the surgical treatment of melanoma. The majority of melanomas are treated surgically, sometimes with other treatments, chemotherapy, even radiation sometimes is used in certain melanoma situations, which feels a little counterintuitive since radiation caused the problem, but it does work in certain situations. But the thicker the melanoma, the wider the recommended excision. And so if you've been in my office, you know we don't hold back. We do big wide excisions. And the thicker the melanoma, we can't be shy. And that's when you stop worrying about scars and start being concerned about getting rid of it. And it takes a while to get there sometimes in people's minds because they don't understand the significance of the diagnosis. But the appropriate wide excisions can be pretty significant. This is Mohs surgery, which Kathy did mention, and I'm curious to get your thoughts at some point. This is a technique to take off lesions. It's absolutely great for certain situations. Other types of skin cancer, basal cells and squamous cells, it's commonly used. It's basically a little minor surgery situation. They take out a little, they go check it. They take out some more, they go check it until they're completely around the lesion and the lesion's gone. It's a beautiful technique for taking care of basal cells and squamous cells. It's used sometimes in some settings for melanoma, differing opinions about whether that's the best use of Mohs surgery or not. I've seen some people very successfully treated with Mohs surgery, but if you're going back to these kind of margins, you know, that's 2 centimeters, that's not the diameter, that's the radius around the lesion. So that's, when we talk about margin, you measure 2 centimeters from everywhere around the lesion, and that turns into kind of a silver dollar size area. Mohs surgery is not going to be the tool you want to use for that, because they're just getting to negative margins with that. All right, so that's where I live. It's funny how I know most people like this, and all my colleagues in the operating room that I don't know as well, the nurses and things, I see them out in public and we all look at each other going, I think I know you, because all we know is this. That's where I live. I want to sidebar, and I threw this in, I couldn't decide where to throw it in, and it's kind of an odd place in the talk actually, and I wore my Kevlar vest today because this is controversial. But I think you need to be aware of it because it's commercially available. Much like when genetic testing came out for breast cancer, and it was commercially available in any doctor's office. You could walk into your primary care doctor, get your blood drawn, and have it sent off to test for genes that would put you at risk for breast cancer, which from a clinician and cancer surgeon's perspective is the absolute wrong way to do genetic testing without any counseling and understanding of who should have it and not. This is kind of tiptoeing into that same world, and it's becoming part of the part of the discussion of melanoma and how it should be cared for. Part of the controversy it's commercially available and commercially developed and FDA approved and readily available. So that makes it accessible to people sometimes without the same thoughtful screening that we might want it to have when it gets used. So gene expression profiling is not the same thing as breast cancer genetic testing, and that confuses people sometimes. Breast cancer genetic testing, we're looking for abnormal genes that put people at risk to later in their life have cancer. And there's other cancers that have genetic mutations that put them at risk. Gene expression profiling is looking at somebody's cellular makeup of their melanoma and see how the genes are acting. It's not identifying abnormal genes. They want to understand how the genes are acting within the cells of that melanoma, and they profile them. The way they do this, and like I said, the information is a little limited because it's proprietary. If you're a big business and you spent millions of dollars developing something, you have a tendency to be very secretive about it, which isn't necessarily the most helpful situation when we're trying to understand how to better take care of cancer patients. So that's where we are now. They've identified 28 genes that they think are significant with regard to melanoma. They study those genes with regard to the proteins that are the downstream effect of those genes on a very small microscopic level within the cells. And then with what I call a secret sauce algorithm that nobody but them knows, they take that genetic output and they crunch some numbers. And they come up with a recommendation of what's called either a high risk or low risk melanoma. This has really only been out 3 years, 2 years? What do you think? 2 years? And so it's still evolving. Its place in the care of patients is kind of unknown. This is just kind of a fancy slide to show you all the different steps of what I just described to you. You know, they take the cells, they get the DNA, they amplify it by making multiple copies, and then you get a printout. And in their hands, their data, their patients, their hands, you see graphs like this where one graph looks like, oh, those people are really high risk, and this other graph looks a lot better. And they say they can subdivide people into different sets of risk. Maybe they can, maybe they can't. Maybe in the future this will be real important Right now, we don't know where it fits, if at all, in the care of cancer patients, but it's out there and you're going to hear about it. Now, it's down to the straight surgical management. Surgical management for melanoma usually involves two components. One is getting rid of the primary lesion, where the melanoma is, and the other is evaluating for any evidence of distant spread, and that's something called sentinel lymph node biopsy. The wide excision, as I said, can vary with regard to the depth of the melanoma. Sometimes it has to vary with regard to the location of the melanoma too, that we'll talk about. Deeper lesions, the deeper the pathologist measures, and it's hard for people to imagine this, but the pathologist actually takes a ruler under the microscope and starts at the top of the lesion and measures how far down it penetrates. The deeper it penetrates, the wider we're obliged to go to get around it. A regional lymph node dissection might be needed if we test the lymph nodes with the sentinel lymph node biopsy technique. Sometimes we go chasing more lymph nodes in that area with what's called a lymph node dissection. And then sometimes, even when people have widespread disease, surgery gets called back in to be part of their care with the goals being different. Sometimes it's a debulking kind of procedure, meaning that the tumor is causing mechanical problems. And while the surgery doesn't have a role in their ultimate treatment and cure, it has a role in their care at the moment. And so sometimes we get involved in that regard. This is kind of typical. The med students and residents call this, it looks like an eye, and it kind of does look like an eye. If that's a lesion, we actually take a ruler, just like the pathologist, measure the distance around the lesion that's appropriate based on the depth of the lesion. And then the reason for this elliptical kind of shape is if you make a big circle, kind of a silver dollar sized circle in somebody, how do you get it closed? You can't just sew it up. It doesn't work that way. It's not an incision like normal incisions. It's a defect now because I'm taking that tissue out. And that tissue that we take out is all the way down to the muscle. People will often ask me, well, how deep, how big is this? How deep do we go? Well, it depends. The skin on your forehead is very thin if you're going down to the muscle. The skin on your backside is much deeper going down to the muscle. And so it all depends on where the lesion is. There's a layer of skin called a layer of tissue called the fascia that's right on top of the muscle that's felt to be a pretty good barrier to keep cells from going through. So you go down to the fascia and take the fascia with it, lift it out kind of as a package, and hopefully have removed all potential cells in the area in the process. It doesn't affect function, doesn't affect muscles or how they work, it doesn't affect major nerves or anything. It's all superficial, but it does take all that tissue out. To get a circle to close, if you try to just put stitches and pull it together, it never will lay flat, it just doesn't work. So you have two alternatives. One alternative is a skin graft, where we actually move skin from one part of the body to the other part of the body. They work great, they heal fine. They always look like a skin graft, because there's a circle or an area where you put the skin there that doesn't necessarily match the other skin. So we work hard to try to get that to work. And the other is you can do this, which is a wider excision, deliberately taking out more than you need in two directions so that you can pull it together as a flat line. So the line becomes very long, but at least it's pulled together in a way that's more smooth. Well, when I talk to patients, how big a margin do I need? Everybody's impulse is to just do something huge, make it gone, make it go away. And that's not always appropriate or necessary. So you have to kind of say, let's talk about the science. But if the lesion's kind of in that middle group, and it happens to be on somebody's back or their flank or their thigh, and making a 2 centimeter margin versus a 1 centimeter margin, all it's going to do is make a long straight line slightly longer. I have a tendency to err on the side of larger margins. The reason for that is people in my world know that the recurrence graphs, meaning how likely is it going to come back here, which is why we're doing this wide excision, to keep it from coming back here. They get better. They get lower the further out you go. Years and years ago, 5 centimeter margins were considered pretty standard. Like 30 years ago, 40 years ago. And they were huge. And then we found out we didn't need to do that and kind of got closer and closer and closer in. So the margins are still important, but more can be better in certain situations. So if I can get a long straight line that's just slightly longer because I went a little wide around it, sometimes we'll do that. But then you see areas like this. If it's not on your thigh or your back and it's on the bottom of your foot, and this is a particular subset of melanomas we see on the bottom of people's feet. In fact, we have a fairly large population compared to the rest of the world here in Memphis of African American people that have had melanoma, and they often get it on the palms of their hands and the soles of their feet, and it's a subset of melanoma that has nothing to do with sun exposure. Because of our population in Memphis being interracial, we have an opportunity to understand that disease process, and I probably see more African American melanoma patients than most surgical oncologists because of that. But you can imagine how tricky this could be. If you measure this is the lesion that's real obvious, but if you look very closely, and I don't know if y'all can see it, these little brown pigmented areas that kind of filter out from the perimeter, the actual lesion is this blue dotted line. So then you measure 2 centimeters out from that blue dotted line, and that outer dot is where you're supposed to go. And truly, not to be too graphic, but truly, sometimes we end up doing amputations or distal amputations because you can't get the margins you need around the skin. And I mean, I not infrequently do partial amputations of the foot and things like that to treat these kind of melanomas, because a location can be very difficult. Then you can take something like this. Well, what do you do with that? If that's an intermediate thickness or a deep melanoma and you're supposed to do 2 centimeter margins around it, that's a tough situation. We work very closely with plastic surgery. I have several plastic surgeons I work with frequently that are all about reconstruction, which is great. It's a little different mindset than the cosmetic plastic surgery world, and they're willing to take on some amazing things. We have, just as an aside, a plastic surgeon here that's nationally known for nasal reconstructions, and there's some flaps and things they can do that are absolutely remarkable, in the end product and how we can reconstruct things. I also work closely with the oculoplastic folks. Melanomas around the eye. You can imagine a melanoma of the upper eyelid, right in the middle of the upper eyelid. How do you do that? It gets tricky, and you need some really skilled surgeons. I have the opportunity to work with some people that can do some amazing oculoplastic reconstruction. The Hamilton Eye Institute, which is part of the medical community here in Memphis, not only has some very talented oculoplastic surgeons that are used to reconstructing eyelids and things, we also have one of the premier ophthalmologists in town taking care of ocular melanoma. We're not specifically talking about that today, but melanoma in the eye has its own set of problems that are different. And so we have some real opportunities here, but these can be tricky locations. All right, lymphoscintigraphy. That's just a fancy word for saying figuring out where the lymph node is that we need to worry about. If the lesion gets deep enough, and this number has changed a little bit over the last few years, so now we say nationally in the NCCN guidelines, which is how we like to stay within the fences of how to take care of somebody, try to stay with those guidelines. They say if a lesion is deeper than 0.75 millimeters, that's the pathologist with his ruler again. If it's deeper than 0.75 millimeters, then it's deep enough to warrant checking the lymph nodes to see if there's any evidence of any spread. This is somebody who's otherwise completely normal on exam. We've already felt everywhere. We don't feel any abnormal lymph nodes, nothing that looks obvious. We're just checking to see if 1 or 2 cells could have moved. There are some subsets of thinner melanoma that still warrant checking the lymph nodes. So the pathology report's very important. You can have a much thinner melanoma that's still considered worrisome because of some things on the path report. Ulceration being a classic one, meaning that they see that the skin surface is broken down. So if we're worried about somebody's lymph node, and we got to figure out which lymph node to check because we can't feel anything that feels abnormal, lymphoscintigraphy is the next step. It's basically a radiologic procedure. If you're not used to looking at these, they just look like gray pixels on a screen. But if you can see the vague outline of a person, that's their head. That's his arms are up in the air, upper torso. This was a primary melanoma of the right upper arm. The dark spots on these are where there's more radioactivity, so that's where they injected the radioactivity. Then it travels through the lymphatic channels and goes to a lymph node somewhere. This one's underneath his arm. We call the axilla or the underarm. So we know that melanoma, if cells have moved, would have gone to that lymph node. So that's referred to as the sentinel lymph node. And that's the one we need to go get. Your body has hundreds, if not thousands, of lymph nodes in it. We don't need just any random node. We need that very specific one. And the interesting thing is, in people that did research on this, if we took everybody in the room and we injected that same spot, we'd have lots of different lymph nodes. So the anatomy is very variable. I could have guessed from the arm it was going to go to the underarm. That's a real common place. That'd be most likely where it would go. But there's 40 to 50 lymph nodes underneath the arm. So we don't just need a random one. We need that very specific one. So lymphoscintigraphy is a way to map it. And I tell patients, this is just mapping. They give you a shot, they take some pictures, and I get a report. There are parts of the bodies, an anatomist named Sappi long ago drew out a kind of cartoon of a human and began to identify areas where you can't predict where things are going to drain. The middle of the back is classic, top of the head is classic. Does it go to the right? Does it go to the left? Does it go to both? And so sometimes these mappings can get very interesting and somewhat confusing. If you have a melanoma in the middle of the back, halfway down, it could go to both underarms and both groin areas. So then you have 4 sentinel lymph nodes you need to evaluate because cells could have moved any one of those directions. Does that make sense? Okay. So once you have your mapping, then this is part of the actual surgical procedure. On the day of surgery, in addition to the wide excision that we talked about earlier, we're going to be doing a sentinel lymph node biopsy. First part was sentinel lymph node mapping. This is sentinel lymph node biopsy, where we're going to actually take out that lymph node. The term biopsy can be confusing because people think it means we're going to take a little sample from it, because some biopsies are just sampling. And a biopsy of a lymph node means we're removing that lymph node completely. Okay? So on the day of surgery, patients get re-injected with radioactive material around the tumor. This does sting. It does hurt. And I've had people swear they're never going to, in their life, ever going to let them do it again. Most people don't hurt that much, but it hurts. And I'm minimizing it. You know, when you say, oh, it's a little bee sting, it's a big bee. So it's important. So they inject radioactivity here. This person would have already had mapping, so we would know anatomically generally where that lymph node is. It's going to make that same lymph node radioactive again because the anatomy hadn't changed. Your body hadn't changed in that way. And so that lymph node that was on the lymphoscintigraphy will now be radioactive again. And the reason that's important is because that's how we find it in the operating room. After you go to sleep, we would inject blue dye around the same area of the tumor. And so now the lymph node that's radioactive is also bright blue. In the operating room, we can use what we call a gamma probe. It's basically a fancy Geiger counter. It reads radioactivity. We move it back and forth over the area where that radioactive lymph node is supposed to be, and we get a hot spot, and then make a small incision and actually take out the lymph node. In this little cartoon, they said 2 lymph nodes. It could be 2, it could be 3. Doesn't matter how many it is. Anything that's blue and radioactive is considered a lymph node at risk for maybe having cells moved to it, so we take them out. If you're one of those people that had mapping that went to like 3 places, then you got 3 little incisions, and 3 lymph nodes are taken out that represent each of those areas. But we're not just, like I said, we're not just taking out any lymph node. This is really specific. And this goes back to some of the biopsy discussion. If somebody does a very large lesion with a complete excision, and you have an incision that's about 3 inches long just from the biopsy, that actually makes it kind of tough for us to do this. This is really dependent on having intact lymphatic channels from the primary lesion. The actual mole, the actual melanoma, the way the cells are moving are through those lymphatic channels. So the mapping is intended to tell us through those channels where cells could have moved. By doing a complete excision, you disrupt all those channels. And so we will get a blue radioactive lymph node based on the scar, but does that represent the same one that we would have gotten if the lesion was intact? Sometimes that's guesswork, we don't know. And we do the best we can with the situation we've got. We'll go ahead and map and take out the lymph node, but if we have a really long incision, I really have some hesitations as to whether that's accurately representing where the cells could have moved. Actually, lymph node dissection, if you take that same patient and the lymph node comes back positive, what do you do then? Well, then we worry, after a long discussion, we're real big here on multidisciplinary approaches is the right way to take care of cancer. So if I have somebody that comes back with a positive lymph node on the first initial surgery, the next step is a conversation. Radiation oncology, medical oncology. We have clinics conferences where we present every patient with a table full of people all deciding how to best take care of them. And most of the time people will then get some scans to look for any evidence of any other problems. And then we'll decide, does it make sense to go on and take out the rest of the lymph nodes? Because if you have a positive lymph node in one area, you may have, as I call them, next door neighbor lymph nodes that also have cancer in them. And we just didn't know that because they weren't the sentinel node. We just took out the one that it mapped to. So you go back and take out all those lymph nodes in that area, and that's called a lymph node dissection. This is just an example of one area. If it was under the arm, there are 3 different areas of lymph nodes. We call them levels, and we would go take those out, send them off to the lab. And as tough as this is, I have to think back to, this is a head and neck example of the same thing. If somebody had a scalp melanoma or a head and neck melanoma that mapped to a neck lymph node, we would go back and take out these lymph nodes if that came back positive on the initial evaluation. I tell the residents that when you get to my age, I don't think I'm very old, but it's amazing the evolution of this disease process and the care for it that's happened in just the last 20 years. When I got out of surgery residency in the 90s, early 90s, there were huge national debates going on about lymph nodes and melanoma, what to do. And you had the take out all the lymph nodes, find out if they're okay camp. You remember that? Find out if they're okay camp. And then you have no, that's just crazy. Don't do that. Only take out the lymph nodes if we know there's a problem camp. And they would stand at national meetings and scream at each other, which was kind of entertaining. But the whole thing was settled by a guy named Donald Morton, who developed this technique called sentinel lymph node biopsy. And I can remember in the mid-90s, it really was a changing paradigm in not only melanoma, but breast cancer, and it became the way we do it. And so we put on courses here in town for every surgeon in the region that would come to teach them how to do this technique because it became so important. And it really has obviated the need for a lot of people to have a lot of normal lymph nodes removed that they didn't need removed. So this has been a great new addition. So, but what do you do with this? This is somebody that had a local melanoma. You can kind of faintly maybe see the scar right there in the middle. And all these little dark spots are melanoma recurrences. It's a multifocal local recurrence. How do you deal with that? Well, there's a variety of ways. If it's small enough, we can still excise it and take out all those areas. And we do those surgeries occasionally. If it's large enough that that's not even feasible, then we have to look for alternative efforts. When someone starts to have this kind of problem, certainly the medical oncologist is involved. We're having long conversations about, do we give something systemic, some sort of medicine that will circulate around the whole body now? Or do we treat the local problem even though it's kind of big and scary looking and save the systemic stuff so when we have a systemic problem? And that's a big debate. I'm interested to hear Dr. Gershman talk later about that. But one of the options that surgeons get involved with, just so you're aware of it also, is infusional therapy. There's 3 different ways to do infusional therapy for melanoma now. This is called isolated limb perfusion. And if you think of it, it's kind of like heart bypass. You isolate the leg so that the rest of the body is not affected in any way. You get catheters in the blood vessels, the artery and the vein go into that leg, and you can actually pump the blood in and out of the leg using a oxygenator, so there's still oxygen going to the leg. You can do this for hours. The rest of the body is not affected at all. The leg's getting the oxygen that it needs, and you're circulating the blood around just in the leg. If you can set up that situation, you can imagine you could give very high doses of chemotherapy to just the leg, which is the idea. So we can use chemotherapy in a way that's specific to the area of the cancer, isolated limb perfusion. It's very helpful in certain situations. It's not been proven as a huge cure effect, but it definitely has been proven to help control some very local disease problems. A simpler version is called isolated limb infusion, where we don't do the oxygen piece, so we don't circulate quite so long. You got about 45 minutes where you can cut off the blood flow to the leg and it won't affect the leg in any way, circulate the chemotherapy around. And the nice thing is the chemotherapy that the leg is seeing is not seen by the rest of the body, so it doesn't affect the rest of the body in the way that high-dose systemic chemotherapy can sometimes. And in very specific situations, this can be a real helpful adjunct to the care and the surgery and the systemic therapy for some patients. And more recently, this is something that we're putting our toe in the water, getting involved with, for people that have isolated liver lesions. And this is really more applicable in ocular melanoma. If you have no disease anywhere else but the liver, how do you take care of that? Well, if it's an isolated spot for most cancers, we go take it out. Surgeons operate on the liver all the time for that reason. Not so often in melanoma isolated, but other types of cancer. Well, ocular melanoma is known for having cancer that recurs in the liver, but it's 100 little bitty spots. It's not one giant tumor. And so you can't go take out 100 little bitty spots. So it's isolated hepatic infusion. And this is kind of high-tech and interesting in that we put catheters in that cut off the blood supply to the liver, and then you circulate around. Same principle as the limb perfusion, but you have to isolate the blood supply to the liver, which is technically a lot more challenging. There's a lot of blood going in and out of the liver. But you can do the same kind of chemotherapy approach to just the liver. And that's showing some promise in certain situations, and it's most applicable, like I said, in ocular melanoma right now. So this is going to overlap a little bit with what Dr. Schwarzenberger was talking about, but there's some sidebar points I wanted to make as well, and then I'm going to bang the political gong a little bit at the very end, just because we have to. How do you follow people afterwards? They've been treated, they've had their melanoma, they're through with all their therapy, we all think everything's great. What's the right way to follow those people? You people. And the answer is, we don't know. We have some recommendations we'll talk about. There's not a whole lot of science in the recommendations. Some of it's intuitive, but we got to figure out how do we follow people. And some of that is predicated on the particular risk of that particular patient. Somebody with a much larger, deeper, more aggressive melanoma, we're going to be more worried about than somebody with a thinner melanoma that we think, okay, that's been taken care of. We don't have much problem there. So prognostic variables, one of them is depth. We look at the depth of the original melanoma and say, what's our risk that we're going to have major problems? And as you can see, the deeper the melanoma, when we're talking about survival, the higher the risk. So we want to follow those people more closely, because if they're going to have a problem, we want to know about it soon so we can do something about it. If you look at stage for melanoma survival, same thing. Depth of the melanoma makes an important difference in the overall survival of those patients. So we can handpick people based on what we think their risks are. This is the slide that Kathy showed that I'm right up there with you, Kathy. I mean, I'm the poster child, and I worked as a lifeguard, and we used to get, start tanning early, because when you were going to be a lifeguard, you were going to fry out in the sun the first day of the summer if you didn't do something, all the wrong stuff. And I come from a whole family of red-headed, blue-eyed people. I got the brown eyes, which that change your skin type. But I'm a rabid sunscreen user, and I brainwashed both my red-headed, blue-eyed children. We used to call them our marshmallow children because they were so fair. Poor things had no hope, and in my world, they were not going to get tanned. So we had our sunscreen ritual where we would go to the beach. We went to the beach every year, and we'd all come home looking like we'd never been to the beach. Because if you use sunscreen appropriately, you can be out 12 hours on the beach frolicking in the surf and be lily white and go home lily white. I tell patients, pale is the new tan. Be white, it's okay. Embrace your paleness. I need to make t-shirts or something. Because, it really, but what do you do with someone like this? You're following this person. They've had a melanoma, and this is what their back looks like. And there's no way they can see all the lesions. There's no way even their spouse can see all the lesions. So some of the tools Kathy talked about that I'll flip back by are, I think, going to be very helpful. We don't have a lot of data to say what tool is the best tool, but we know that if we find it early, it's going to be better for the patient. And we know that somebody that's had a melanoma has an increased risk of getting other melanomas, same skin, they lived in the same place, had the same sun. So we want to follow them carefully. So these are the follow-up recommendations, and these are based by depth. So the deeper the lesion, in this particular article they were talking about, the more aggressive the follow-up. I just picked one that I felt comfortable with, and I kind of settle in right here for most patients. I tell, partially because uniformity helps me, because then we have a system of how we do it. For the first 3 years, I like to see somebody every 3 months. Get them completely undressed, look them over head to toe, look specifically where their melanoma was very carefully, evaluate for lymph nodes if we can feel anything, and have them do that every 3 months. We get to be good friends. We see each other a lot. We get to 3 years and we start spreading it out to 6 months. So for a total of 5 years of follow-up. There's nowhere that's chiseled in stone is the right way to do it. So I tell patients, if I tell them to come back in 3 months, they start to see a problem 2 weeks after I've seen them. They think, well, I've got to wait 3 months. I'm like, no. Come anytime that there's a problem. This is the screening stuff. This is just the checkups. And so I think that's important. And we partner with dermatology. Some dermatologists are very focused on melanoma and are very happy to see these patients and follow them regularly. Same for some primary care doctors. Some primary care doctors are like, oh, no, I don't want anything to do with it. So they come see me every 3 months because they need to see somebody who's going to follow them carefully. This is what Catherine's referring to. Try this at home. I challenge you. Get a hand mirror and see if you can see every inch of your own body. You got to be kind of an acrobat. It's really kind of hard. You can do it. I've done it, but it's hard. But I tell people, try. Just because it's not easy doesn't mean you shouldn't try. Okay, so you missed 5% of your body you couldn't see. The other 95% you looked at, and that's good. So we encourage people to do this. I tell them, don't freak out, as far as doing it daily. And don't turn your life upside down over this. But just say, okay, first day of the month, I'm going to take a good look. I'm going to really look around. And if I see something, I'll bring it to someone's attention. It's a good practice. Dermascopy, where you can get, as Kathy was talking about, magnified views of lesions. They make these nifty dermascopes now that can actually hook into your iPhone, take a digital picture of what you're looking at, and you can follow it over time. This is an example of kind of serial imaging, where the same patient, 14 months later, you could see on a very close-up view that lesion has changed. That's a significant change that you might not catch with the naked eye. So this becomes helpful. Now, tanning beds. This is a cartoon, obviously. If you pay more, you get more cancer. That's what this is trying to convey. I see lots of patients with different types of skin cancer, a lot of melanoma, that is obviously directly related to tanning beds. I've had patients that worked in tanning salons. I've had patients that own their own tanning bed, and they're thinking through the process, obviously. The diagnosis is new to them, and they'll say things like, well, what do I do with my tanning package? And I said, I suggest you either get your money back or just ignore it. And I had somebody say, well, what do I do with my tanning bed? I said, well, I couldn't come up with a good answer, because there's no good use for putting it on the curb. I came out with something like, well, give it to somebody you hate. What do you do? but the people that are really enmeshed and that is part of what they do routinely, it's really hard to extricate them from it sometimes. There are even a subset of people that talk about people being addicted to tanning. It gives them, they say, some sense of wellness, that it's real important to them. So it's hard, but it's definitely something that we have to address as part of the care of patients. It's just one statistic. 35% of young adults have reported using tanning beds. 35% of young adults have reported using tanning beds. Those who have been tanning before the age of 35 increased their risk of melanoma by 87%. So it's almost a doubling of their risk. So it's not an insignificant problem. And the issue that I see that just makes you cringe is part of the fabric of the tanning industry in our part of the world here in the South, where we say y'all, is we have lots of pageants, little girls in pageants, right? And this is for real. Moms take their 6 and 7-year-olds to the tanning beds for the pageant. They get them ready, and they need to be tanned because that's going to be better on stage, I guess, whatever it is. And so little bitty people are being taken to tanning beds to get ready for these pageants. And if you ever met a pageant mom, they are rabid about being in the pageant. You know, it's a big deal. It sounds kind of comical, but it's for real. And those people can't take back what happened when they were 8. It's there. The damage is there. So doing something to intervene really makes a difference. We showed you the incidence slide of melanoma, you know, that red line at the very beginning going up from 1975 to now, how much it's increased. This is kind of interesting when you tease it apart. Well, what's the group that it's increasing? Well, it's the tanning people. That's us. Pale people like me that want to be tan. Yeah.
This might sound like a stupid question. How much does climate change or the change in the ozone layer make a difference in the?
I don't think anybody knows. Everybody speculates that it's certainly worse. And as our ozone is deteriorated, or you live in a part of the world that maybe has less ozone because over a major metropolitan area, is that intuitively I would say it can't be better, but I don't think we really know. But you can see in these different genetic subgroups down here, their incidence of melanoma is not going up at all. Those are those palms of the hand, soles of the feet kind of folks who are suddenly even in part of the discussion. I had the pleasure of helping take care of some folks at St. Jude over the years. I mean, their baby's born with melanoma. Incredibly rare, but it happens. So not all melanoma is sun-related, but we know for sure about 95-98% of it is, and so that's where we can make a difference. Tanning bed utilization, interestingly, as you saw that number go up, this is the utilization in the tanning industry in the mid-90s, early 90s. It really kicked off, the percent of young people using indoor tanning beds. And it's leveled off. It's been high ever since the kind of mid-90s when the fashion trend shifted and everybody wanted to be brown like a coconut because that was considered beautiful. We need to go back to the Victorian age where that meant you were a laborer, you know, and being pale meant you were high-end. This is a map of the states in the United States that have tanning bed restrictions, and this is where Kathy and I have many conversations, and she's had a lot of personal experience, done great things in Vermont. As soon as I heard that, I started talking to her, saying, "We've got to do it here," because Tennessee's law is a joke. They have a law, so they say we have a law. I mean, it's not enforceable. It's not enforced at all. But the green states are the ones that have actually passed laws, and this is as of, I think, 2015, that's fine, have passed laws that restrict anyone under 18 from using a tanning bed. And in my mind, that's a very low bar restriction, really. I mean, we live in the United States where you're free to do things that don't make good sense, like not wear a helmet when you ride a motorcycle in certain states. I mean, people want that freedom, but at least under 18, that would be a big step. And also, it's the sun you get at those at young ages that really makes a difference in your risk as well. The yellow is the states that have some sort of law, and the red is the states where you can get in, 14 and 15, teenagers are allowed to tan with their parental consent. I didn't know it had to be notarized. Does it have to be notarized, supposedly? Yeah. I could just picture teenage friends writing notes for each other, signed to mom, and going into a tanning. I can guarantee you they're not looking for the notary, if they're even looking for the note. So we got work to do. In Louisiana and Texas, Dr. Gershenwald, who is at MD Anderson, a melanoma expert there, he and I were talking about this a few months ago, and he's been well involved in the legislature in Texas and helped Louisiana. And I was like, please come to Tennessee and help us, because I think we've got some work to do. So that was kind of the skimming over the top of the surgeon's role in the care of melanoma. I'm happy to answer questions. I don't know, timeline-wise, we're probably a little over, so I will be.
We'll do questions at the end.
Absolutely, I'll be here. Thank you.